Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome back to OBG with Sadia Dries, and we are continuing our labor module lecture number 6 Intrapartum Care based on NICE guideline 235, and today we are moving into part 3. Now before we begin, let me give you a very simple clinical situation. A woman in established labor says, "Doctor, I want an epidural." Sounds straightforward, right? But from an examination point of view, that one decision opens up multiple questions. Do you routinely preload her with IV fluids? How frequently should you monitor her blood pressure? Does she now have to remain in bed? Do you stop the epidural when she reaches full dilatation? And how long can you delay pushing? And when exactly do you need continuous CTG? These are the details where very similar looking questions can completely change the answer. So today, I don't want you simply to memorize epidural analgesia. I want you to know what happens before it, during it, after it, and why. And after regional analgesia, we'll move forward into the term pre-labor rupture of membranes and assessment and care during the first stage of labor. So stay with me because there are some very testable numbers coming up. Okay. So, what exactly are we covering in this part? We'll start with regional analgesia, how it is established. We will learn how it is maintained, maternal and fetal monitoring, and what happens when the woman reaches the second stage. Then we'll move to another extremely common clinical scenario, the term pre-labor rupture of membranes. And after that, we'll clarify the difference between latent and established first state of labor, discuss the initial assessment of a woman presenting in labor, vaginal examination, indications for transfer to obstetric-led care, eating and drinking during labor, and ongoing maternal and fetal observations. So this is a very practical session. These are not real textbook situations. These are women you will see every single day in a labor ward. And for exam candidates, keep your eyes on the numbers. Whenever NICE give you a specific time interval, volume, or frequency, there's a very good chance somebody can turn into a single best answer question. Let's begin with regional analgesia. Our patient requests an epidural. What should happen first? One important practical step is to ensure IV line, but now comes a classic misconception. Sometimes the woman says that some candidates automatically think epidural means IV fluid preload. Not necessarily. NICE specifically advises that we should not routinely give an IV load preload before establishing a low dose epidural or a combined spinal epidural. And the word important here is routine. This does not mean IV fluids can never be refilled. If the woman is hypotensive, dehydrated, bleeding, or there is another clinical indication, of course, fluids may be appropriate, but simply because she's about to receive low dose regional analgesia does not mean that everybody needs routine fluid loading beforehand. So imagine the question. A healthy woman in labor requests an epidural. She is hemodynamically stable. Which intervention should routinely be performed before low dose epidural analgesia? If one option says give a routine large volume IV fluid preload, that should immediately make you suspicious. Epidural does not equal routine IV fluid preload. Keep that sentence in your head. Okay, now the epidural has been established. Are we finished? Absolutely not. This is actually when monitoring becomes particularly important. During the establishment of regional analgesia and after any further bolus of 10 millimeters or more, maternal blood pressure should be measured every 5 minutes for 15 minutes. I want you to remember that as a small formula, 5 by 15 after 10. 5-minute blood pressure measurements for 15 minutes after a bolus of 10 milliliter or more. Why? because sympathetic blockade can cause vasodilatation and maternal hypotension. And maternal hypotension is not just a maternal number on the monitor. A significant fall in the maternal blood pressure can reduce uteroplacental perfusion and therefore potentially affect the fetus as well. Now, let's say the epidural has been placed, but the woman says, I am still in significant pain. How long do we wait before thinking this needs review? If she is not pain free, 30 minutes after each administration of local anesthetic or opioid solution, ask the anesthetic to review her. Don't just keep reassuring her indefinitely that the epidural will eventually work. Persistent pain may indicate an inadequate or asymmetric block or a catheter related problem. Next comes the block itself. The sensory block should be assessed hourly, and the motor block should be also assessed hourly if the patient is not mobilizing. Here is another useful red flag. If she is unable to perform a straight leg raise, if she is unable to perform a straight leg raise, the anesthetist should review her. So already we have several high yield numbers, 5-minute intervals for 15 minutes, persistent pain, review at 30 minutes, sensory block hourly, motor block when not mobilizing hourly. These are exactly the sort of numbers examiners love to swap around in the options. Now, here is something I really want you to challenge. A woman has an epidural. Does that automatically mean lie down, don't move, stay in bed until delivery? No. An epidural does not automatically mean bed rest. Women with regional analgesia should be encouraged to adapt whatever position they find comfortable. That may be an upright position, that may be a lateral position, or another comfortable position of her choice. What should we avoid? Prolonged lying completely flat on the back. Think about the physiology. A gravid uterus in the supine position can compress the inferior vena cava, reduce the venous return, and contribute to hypotension. And in some women, mobilization may actually be possible with a low dose epidural. But this is not, she feels okay, so let her walk. We need to establish that she has adequate leg strength and sensation. This should be confirmed by a trained staff, and appropriate assistance should be available. So in an exam question, if you see women with a low dose epidural, good leg strength, adequate sensation, and trained staff available, and then they ask whether she can mobilize, don't reject the option simply because she has an epidural. Epidural does not mean automatic bed rest. Am I clear so far? That's the principle. Okay, now let me ask you a question that causes unnecessary confusion. The cervix is fully dilated. Should we switch the epidural off so that the woman can feel contractions and push? No, not routinely. Once regional analgesia has been established, it should generally be continued until after the baby is born, the third stage is completed, and any necessary perineal repair has been performed. Think from the patient's perspective. She has had an effective analgesia throughout labor, and now we are approaching birth and possibly perineal suturing. Why should we deliberately remove effective analgesia without a good clinical reason? So remember, do not routinely stop an epidural for delivery, and certainly don't think full dilatation automatically means epidural is off. This takes us perfectly into the next question. If she reaches full dilatation with an epidural but has no urge to push, what should we do now? This is one of the most examinable parts of today's section, so focus here. Okay. So now this is one of the most examinable parts of today's section. So focus here. Our woman is fully dilated. She has regional analgesia. The baby's head is not well, and she needs to watch. Do not necessarily. There can be a period stage parity. For a multiparous woman, delayed directive unless she has an urge to push or the babies will then actively encourage pushing during contractions. So remember, in nulliparous women, 2 hours, and multiparous women, 1 hour, and nulliparous up to 2 hours, multiparous 1 hour. And please don't reverse these in the exam. Now, another trap. Does the presence of an epidural itself mean we should routinely start an oxytocin infusion during the second stage? What do you think? No, do not really use oxytocin in the second stage solely because the woman has regional analgesia. If there is a separate indication related to contraction or progress, that becomes another clinical decision. But epidural alone is not an indication for routine oxytocin. That distinction is very important. Am I clear so far? Now, we have monitored the mother. What about the baby? During the establishment of regional analgesia, perform continuous CTG for at least 30 minutes. And here is where today's number connect beautifully. If a further bolus of a low-dose solution of 10 millimeters or more is given, again, perform continuous CTG for at least 30 minutes. So your memory shortcut is if you're giving 10 millimeters or more, 30 minutes CTG. Why? Because regional analgesia can produce acute maternal hemodynamic changes, particularly hypotension, and those changes may affect the fetal heart rate. So now notice how maternal and fetal monitoring fit together. After a significant bolus, mother DP every 5 minutes for 15 minutes, and in baby, continuous CTG for at least 30 minutes. That is a lovely single best answer question. If the examiner gives you 4 different combinations of BP frequency and CTG duration, you should now be able to pick the correct one. Okay. Now let's look at how regional analgesia can actually be established. Broadly, we can use an epidural or a combined spinal epidural, which we commonly abbreviate as CSE. So how do we choose? A useful clinical distinction is the speed of analgesia required. If rapid analgesia is required, a combined spinal epidural can be used. Why does it work quickly? Because the spinal component provides a rapid onset, while the epidural catheter allows ongoing analgesia to be maintained. For combined spinal epidural, the intrathecal component can use bupivacaine or an equivalent local anesthetic with fentanyl. For epidural analgesia, we use a low concentration local anesthetic with an opioid and a fentanyl. The trigger principle here is more important than memorizing drug names in isolation. So if you are thinking about rapid onset, that rapid onset is needed, Think combined spinal epidural, ongoing low-dose retail analgesia, epidural approach. And remember that modern labeled epidurals aim for good analgesia without producing an unnecessary dense motor block. Once the epidural is working, how do we maintain it? NICE recommends a low concentration local anesthetic combined with an opioid. For example, bupivacaine 0.0625 to 0.1% or an equivalent low concentration local anesthetic combined with fentanyl 2 micrograms per milliliter. So don't just memorize the concentration, understand the philosophy behind it. We want analgesia without unnecessary motor blockade. In other words, control the pain, but preserve the maternal function as much as possible. And this connects directly with the previous slide where we discussed mobility. Higher concentration of local anesthetic produce dense motor blockade. Therefore, routine use of high concentration local anesthetic solution, for example, bupivacaine 0.25% or above, should be avoided for labor epidural analgesia. How can the epidural then be maintained? There are several options, including patient control epidural analgesia, program intermittent epidural boluses, or intermittent boluses administered by a trained professional. Principle is low concentration local anesthetic plus opioid causes effective analgesia with less motor blockade and better potential mobility. That's the clinical logic behind the recommendation. Okay, pause here. Before we leave the regional analgesia, I want you to answer these quickly in your head. Question 1. Routine IV fluid preload before a low dose epidural? No. After establishment of further bolus of at least 10 ml, how frequently do we check the blood pressure? Every 5 minutes for? Yes, please, 15 minutes. Question 3. A woman is still in significant pain 30 minutes after administration. What you will do? Anesthetist review. Question 4. Sensory block, how much it should be monitored? Hourly. Does epidural automatically mean bed rest? No. Do we routinely stop the epidural when she reaches full dilatation? No. Continue it through birth, completion of third stage, and any necessary perineal repair. Shabash. Nulliparous women at full dilatation with regional analgesia, no urge to push and head not visible, then delayed pushing for up to 2 hours. Or अगर multiparous में हो तो 1 hour. Further low dose epidural bolus of 10 ml or more, then CTG, continuous CTG for at least 30 minutes. And finally, need rapid analgesia, then combined spinal epidural. Excellent. If those answers came naturally, you have already converted our relatively dense guideline section into a handful of clinical rules. And now we are moving from analgesia to another labor ward scenario with timing changes management completely. A woman at term whose water had broken, but labor has not started yet. So what do you offer? How long can you wait? When should you induce? And if what she is GBS positive, that is where we go next. Now let's move to our second major section, pre-labor and I want to hand a very common call to maternity service. A woman who is 38-week pregnant calls and says, I think my water have broken, but I don't have any contractions. What should I do now? Stop here. Do we tell every woman with suspected rupture of membrane to immediately rush to hospital? Not necessarily. And do we reassure every woman to simply stay at home and wait? Again, no. The first step is, yes, please, risk assessment. At term, meaning from 37 weeks onward, the initial assessment of suspected pre-labor rupture of membranes can begin by telephone triage. And one of the first questions is extremely simple. When did the membranes rupture? Because duration matters. But timing alone is not enough. And we then need to identify whether there are maternal or fetal risk factors that require urgent assessment. So throughout this section, I want you to think of term prom in two pathways. Low risk prom, where we have time to discuss options, versus prom with red flags, where Assessment becomes urgent. Let's see what those red flags are. This slide is clinically very important. During telephone triage, you are not trying to diagnose everything over the phone. You are trying to answer one critical question. Is it safe for this woman to wait for routine assessment, or does she need urgent in-person maternity assessment? So ask specifically about the LICA. Is it clear? Or is there meconium staining? Has its color or smell changed? Is the LICA offensive? Because offensive LICA should immediately make us think about the possible infection. Ask us about vaginal bleeding or blood stain LICA. Ask about fetal movement. Use fetal movements are not something. Ask about pain. Indicate pathology requiring assessment. And ask how the woman herself feels. Is she feverish, shivering? Is she feverish? Is the liquor effective? We will ask about the general condition. We will ask about the whether patient has any infection-like condition, whether she has intermittent contraction-like pain, and ask how the woman herself feels. Is she feverish, shivering, generally unwell, or concerned about her condition? Then consider known pregnancy risk factor. Is there a GBS-related risk? Is a lie or presentation abnormal? Is there known fetal growth restriction or a low-lying placenta? And any of these factors changes the pathway. Am I clear so far? So here is the practical rule. Any red flag or uncertainty, urgent in-person maternity assessment. Don't this is useful exam principle. Telephone triage is appropriate for initial assessment, but it does not replace clinical assessment when risk factors are present. So I hope that it's clear up to you till now. Any questions, if you have, you can ask in the comment box. Now, we talk about that there is a term from, but now there are no risk factor. Let's return to our original patient. She is at 38 weeks. Her waters may have broken. Liquor is clear. Baby is moving normally. No bleeding, no continuous abdominal pain. She feels completely well. And there are no other maternal or fetal risk factors. What happens now? If she has concerns or she would like immediate induction of labor, arrange an in-person review as soon as possible. Otherwise, if there are no risk factors and she is comfortable waiting, she should be reviewed within 12 hours. So that's an important number. Suspected term from with no risk factors removed within 12 hours. And of course, she should be told to contact maternity services earlier if anything changes. So don't interpret within 12 hours as ignore everything until 12 hours have passed. If she develops bleeding or reduced fetal movement or offensive or abnormal like a fever, pain, or simply becomes concerned, she should contact the maternity services earlier. Now, once she arrives, and the very common exam question appears, how are you going to confirm that the membranes have actually ruptured? This is exam gold. A woman says, am I clear so far, or there are any queries you can ask? If you have any queries, you can ask in the comment box. Now, this slide is exam board. A woman says, my waters have broken. Do you perform a specular examination, everyone? No. If rupture of membrane is already certain from the history and clinical situation, routine speculum examination is not routine speculum examination is not required just because that patient has ruptured the membrane. But what if you are uncertain? She says, I felt a little wetness. I'm not sure whether it was urine discharge or my waters. Now the diagnosis is uncertain. In that situation, perform a speculum examination to determine whether the membranes have ruptured. So remember, uncertain pre-labor rupture of membrane, then perform the speculum examination. Now here is the second part. If she's not having contraction, avoid routine digital vaginal examination. Why? Because repeated digital examination after membrane rupture can introduce ascending organisms and potentially increase the risk of infection. And if she's not in labor, what useful information are you gaining that justifies that risk? So this is one of those situations where doing more examination is not necessarily better medicine. So if rupture membrane is uncertain, you will do the speculum examination. If rupture membrane is certain, routine speculum examination not required. And if there are no contractions, avoid the digital vaginal examination. Very, very tested. Okay. Now, what you will do. Now, let's say we have confirmed term pre-labor rupture of membrane. The next step is not simply your waters are broken, so we are inducing you. This requires counseling and shared decision making. There are two key pieces of information the woman needs to understand. First, the infection risk, the risk of serious neonatal infection after the term pre-labor rupture membrane is approximately 1%, compared with around 0.5% when membranes remain intact. So roughly speaking, the risk is increased, and it may increase with time after rupture. So, but here is the other side of the discussion. Many women will go into labor spontaneously. Approximately 60% will labor within the 24 hours after their membrane rupture. And that's why management is not simply black and white. We are balancing two realities. Waiting gives a significant proportion of women the opportunity to enter the labor spontaneously. But prolonged rupture increases concern about the infection. That balance explains the management option we are about to discuss. And understanding that reasoning is much safer. Top cause is one very short, then we'll come to that shortly. So, what do we offer a woman with term from 37 weeks? In an otherwise uncomplicated situation, option one is expectant management for up to 24 hours, meaning we allow time for spontaneous labor to begin. Option two is induction of labor as soon as possible, and this should be shared decision. With this of each option and take I know there is some glitch. Okay. So we were discussing that if at 37 weeks, and we will go for expectant management for up to 24 hours. And second option is induction of labor as soon as possible. And this should be a shared decision. We discuss the risk and benefits of each option and take the woman's circumstances and preferences into account. Am I clear so far? So this is important because modern intrapartum care is not doctor decide, the patient follows. The woman should understand the available option, participate meaningfully in the decision. So if she says, I understand the risk and I prefer induction now, that is an appropriate option. If she prefers expectant management and there are no contraindication or additional risk factor, waiting for up to 24 hours is also an option. But what happens if those 24 hours pass and labor still has not started? This is where the timeline becomes very important. Let's say she chooses expectant management. 6 hours pass, no labor. 12 hours, still no labor. And we'll reach approximately 24 hours after the rupture of membranes. What now? If labor has not started naturally after approximately 24 hours, offer induction of labor. So your memory line is at term from at 24 hours, offer induction of labor. Notice the wording again, induction of labor offer. And if a woman decides to continue expectant management beyond 24 hours after counseling, her decision should be respected and the ongoing plan discussed with her. So 24 hours is the major management point, but it does not remove shared decision making. Now, while we are waiting, we still need to think about fetal well-being. Suppose our patient has chosen expectant management and is not yet in labor. Do we put her on continuous CTG for the entire waiting period? No. In an otherwise, who is not in including us about fetal movements, fetal heart rate. In an otherwise low-risk woman who is not in labor, fetal well-being should be assessed appropriately, including asking about the fetal movements and assessing the fetal heart rate. This assessment is performed at the initial contact, and if she remains out of labor, again every 24 hours after the membranes. While expectant management continues and the woman herself has a crucial role in the surveillance, she should be advised to report any reduction in fetal movements immediately. Not wait until your next schedule review, immediately. And while we're discussing waiting, counseling should also include maternal signs of infection such as feeling unwell, fever, or changes in the color or smell of the vaginal loss. So expectant management does not mean no management. It means structured observation, clear safety netting, and knowing exactly when the situation has changed. Now, let's look at another important consequence of prolonged rupture. If labor has still not started 24 hours after rupture membrane, the place of birth matters. The woman should be advised to give birth in a setting where there is access to neonatal services. Why? Because prolonged rupture increases concern about the neonatal infection. And after birth, if rupture membranes occurred more than 24 hours before the onset of established labor, the baby should generally remain in hospital for at least 12 hours of observation. So notice the two numbers: from more than 24 hours neonatal capable setting, and after birth at least 12-hour neonatal observation in the relevant prolonged rupture membrane situation. This is the kind of detail that can easily appear in an exam question because the examiner may offer you 4 hours, 6 hours, 12 hours, 24 hours. But now we come to the exception I warned you about earlier. The patient has term prom, but she is GBS positive. Does she still get the option to wait for 24 hours? This changes the management. This is probably the highest yield slide in the entire prom section. Imagine a woman at 39 weeks presents with ruptured membranes. She's not contracting. She's well. Liker is clear. Baby is moving. Everything looks low risk, except her records show group B streptococcus was detected during this pregnancy. What do you do? Yes, please. What do you do? Do you say around 60% of women labor spontaneously within 24 hours, so let's wait? No. If a woman with term prom has had a positive group B streptococcus test at any time during the current pregnancy, offer immediate induction of labor. Immediate induction of labor. And similarly, if she has previously had a baby who developed a GBS infection, offer immediate induction. Don't wait for 24 hours. If a cesarean birth had already been planned for another indication, then offer cesarean birth rather than waiting for spontaneous labor. The reasoning is straightforward. Prom removes the protective membrane barrier and GBS increases the neutral infectious risk. So the balance that allowed up to 24 hours of expected management in uncomplicated term prom changes. So term prom plus GBS, don't wait for 24 hours. Offer immediate induction. This is exactly the kind of exam question where they give you a perfectly stable woman to tempt you into choosing expected management. The clue is hidden in one line. GBS positive in current pregnancy. Once you see that, your management changes. So, okay, before we leave prom, let's see if you can answer these without looking at the slide. A woman at 38 weeks thinks her womb water have broken. Can initial assessment begin by telephone? Yes. She has meconium stain, liquor, and reduced fetal movements. Urgent in-person maternity assessment. No risk factor, and she's happy to wait review within 12 hours. She's unsure whether her membranes actually ruptured. Do speculum examination. Membranes have clearly ruptured, and she has no contraction. Routine digital vaginal examination should be do avoid it. What is the approximate risk of serious neonatal infection with term from about 1% compared with around 0.5% with intact membranes, and approximately how many women labor spontaneously within 24 hours? Around 60%. For uncomplicated term from, what are the initial management choices? Expected management for up to 24 hours or induction as soon as possible. 24 hours pass and labor has not started. What you will do, you will offer the induction of labor. Reduce fetal movement while waiting, do to report immediately. And finally, the one I really want you to remember, term from plus positive GBS in the current pregnancy, immediate induction of labor. Excellent. So if you remember only 3 lines from this section, remember this. Uncertain from to speculum examination, uncomplicated term from up to 24 hours for induction of labor now, and induction of labor. And now that we have dealt with a woman whose membranes rupture before labor, our next question becomes even more fundamental. When do we actually say the labor has started? Is a woman with painful contractions in a cervix of 2 centimeters in established labor? What about 3 centimeters? And what exactly separates the latent first stage from the established first stage? So when we talk about, now we are moving to the first stage of labor, and before discussing monitoring and management, we need to be very clear about one basic concept. When is a woman actually in established labor? Let's begin with the latent first stage. According to NICE, the latent first stage is a period when the woman is having contractions and there is some cervical change. That cervical change will involve the position, the consistency, the effacement, and dilatation of the cervix. But the important number here is 4 centimeters. During the latent first stage, cervical dilatation is up to 4 centimeters. And another important point, this phase does not necessarily progress continuously. Contractions may come and go, their intensity may vary, and the woman can remain in this phase for quite some time. So don't diagnose established labor just because a woman is contracting. Remember, contraction plus cervical chain up to 4 centimeter is latent first stage. This distinction becomes very important when we decide whether the woman needs admission, vaginal examination, or simply support during the early labor. Now, compare that with established first stage of labor. This is a very important definition and definitely something I want you to remember for the exam. Established labor means that the woman has regular contraction and there is progressive cervical dilatation from 4 centimeter. Notice the wording carefully. It is not simply cervix is 4 centimeter. It is progressive cervical dilatation from 4 centimeter with regular contraction. This is the exam point. If an exam question gives you a woman with painful contraction, but there's no progressive cervical change, don't automatically label her as being in established labor. Similarly, one isolated cervical examination showing 4 centimeter has to be interpreted in the clinical context. So keep this line in your mind: established first stage and regular contraction plus progressive cervical dilatation from 4 centimeter. You will see why this definition matters when we discuss delay in the labor lately. Okay, so what happens when a woman first contacts maternity service because she thinks she's in labor? The assessment will actually begin over the telephone. Telephone triage helps us decide whether she needs a face-to-face assessment. We ask about her contraction and fetal movement, vaginal loss, whether the membranes have ruptured, bleeding, her general well-being, whether there are any maternal or fetal concerns. If face-to-face assessment is required, depending on the woman's circumstances and the maternity service, this may occur at home, in a midwifery-led unit, or in an obstetric unit. The key principle here is that not every woman with early contractions automatically requires hospital admission. We assess her first, identify the risk, and then decide the most appropriate place of care. So in an exam, don't jump directly from she has contractions to admit to labor ward. First, ask yourself, is she actually in established labor? And are there any risk factors requiring hospital assessment or admission? So, during early assessment, don't make the interaction only about contractions and cervical dilatation. Start with the woman herself. Ask, how is she feeling? What are her wishes and expectations? Does she have any particular concerns? And very importantly, has she noticed any change in baby movements? This last question is particularly important because reduced or altered fetal movement may change our assessment and management. Then explain what she should expect during the latent labor. Tell her that early labor can take time and contractions will not immediately lead to established labor. Discuss ways of coping with pain, explain when and how she should contact maternity services again, and agree on a clear plan of care. This is a good maternity care because we are not simply telling the woman, we are not in labor, go home. We are giving her information, reassurance, safety netting, and a plan. And that difference is very important clinically. Now, here is a beautiful exam trap. A woman can have very painful contractions without progressive cervical chain. Pain does not diagnose established labor. Let me repeat that. Painful contractions do not automatically mean established labor. If she is not established labor, we should still take her pain seriously, offer individualized support and appropriate analgesia if needed. Depending on the assessment, she may remain at home or return home rather than being admitted. However, there are exceptions. If there is significant risk that she may give birth without skilled attendance, or if she's become significantly distressed, then her care needs to be individualized. When the examiner gives you dramatic painful contraction, don't let the severity of the pain distract you. Ask, is there is progressive cervical dilatation? Because pain alone does not diagnose established labor. Once we assess the woman, there's another principle that NICE emphasizes beautifully. Before looking at the numbers, charts, and examination, listen to her story. Find out what has been happening and what matters to her. Consider her preferences, her emotional needs, any personalized birth plan that has already been discussed during pregnancy. This is particularly important because labor care should not become a series of procedures performed on a patient. The woman remains an active participant in decision making throughout the labor. And after this initial assessment, reconsider whether the originally planned place of birth and midwifery led care remain appropriate. Am I clear so far? If new risk factors have developed, the appropriate setting of care may change. So the assessment is both clinical and individualized. Now, let's make our assessment more systematic. First, review the antenatal. Am I clear? So, I'm rushing. If you find that I very fast, you the makeup box. You need your review about my lecture and any queries. Okay. First, the and screening result. Look at the personalized care plan and identify any risk factor, particularly factors associated with fetal compromise or hypoxia. Then ask about the contractions. How long are they lasting? How strong do they feel? How frequently are they occurring? How is she coping with pain? And has she already used any analgesia? And also check whether she requires intrapartum antibiotic prophylaxis for group B streptococcus. Then record the maternal observations, the pulse, the BP, the temperature, the respiratory rate, the urine complete examination when appropriate, and assess any vaginal loss. And don't treat these observations as isolated first. For example, maternal tachycardia plus fever plus offensive is a completely different clinical picture from an isolated mildly raised pulse in an anxious woman. So always interpret observations in context. Okay. Now we have assessed the mother. Now we assess the baby. It is equally important. Start by asking about the fetal movements, particularly whether there has been any change during the previous 24 hours. Then perform the abdominal examination. Assess the fundal height, the fetal lie, the fetal presentation, position, and engagement of the presenting part. Also assess the contractions abdominally. Then assess the fetal heart rate. At initial assessment, auscultate the fetal heart rate for at least 1 minute immediately after occupation. And here is another small but intermittent but important clinical point. Palpate the maternal pulse at the same time. Please, the exam question, this is important for your talks point of view, that whenever you are palpating the maternal palpating and feeling the fetal heart for at least 1 minute, palpate the maternal pulse at the same time. Why? Because we need to make sure that what we are calling the fetal heart rate really is okay. Now we come to the most important thing, that when should you offer vaginal examination? It is very important, and you should know first thing that a common misconception is that every woman presenting with contractions immediately needs a vaginal examination. Not necessarily. If after your initial assessment, you are uncertain whether she is in established labor, a vaginal examination may be helpful, but it is not automatically necessary in every woman. On the other hand, if she appears to be in established labor, then offer a vaginal examination to assess the cervical dilatation and other relevant findings. Notice again the language, offer a vaginal examination, offer, okay? Not perform it regardless, because vaginal examination is an intimate examination and requires a clinical indication, explanation, consent. And this leads beautifully to next slide. Before a vaginal So now, before a vaginal examination, ask yourself a simple question. Is then examination necessary? This question should come before every vaginal examination in labor. If it is necessary, why you are recommending it and what the examination involves. Obtain informed consent, ensure privacy, maintain the woman's dignity and comfort throughout the examination. And afterward, explain your findings sensitively and clearly. Most importantly, consent is not a one-time event. A woman can decline the examination before it begins, and even after giving consent, she can ask you to stop at any time. That is a very important principle of respectful maternity care. So, as therefore, I have to do it. Am I clear, or whether there was a glitch? I will repeat it. A woman can decline the examination before it begins. That's a very important principle of don't think of vaginal examination as simply 4-hourly vaginal examination. Therefore, I have to do it. The correct approach is clinically appropriate, explain, take consent, maintain privacy, dignity, and then do examination and communicate the findings with the patient. And remember this, because when we move into established, we will discuss the recommended frequency of vaginal examinations and the other maternal and fetal observations the first day. That section is extremely high yield because there are several numbers that NICE loves and the examiner loves even more. So now that we know how to offer a vaginal examination, the next question is, what exactly are we assessing during vaginal examination? And I want you to think beyond cervical dilatation, because vaginal examination is not simply about that cervix is about 5 centimeters. There are 6 important things. First, assess the station of the presenting part. How far the presenting part has descended in relation to the maternal ischial spine. Second, determine the position of the presenting part. In a cephalic presentation, we use a sutures and fontanella to identify the fetal head position. Third, assess for caput and molding. These become particularly important when labor is not progressing as expected, because increasing caput or significant molding may suggest difficulty with descent. Fourth, assess the cervical effacement, how much the cervix has shortened and thinned. For fifth, assess the cervical dilatation. And finally, assess the membranes. Are they intact or ruptured? If the membranes have ruptured, also think about the characteristics of the liquor. Is it clear, meconium stained, blood stained, or offensive? So whenever an examiner asks, what will you assess on maternal examination? Don't stop at dilatation. Think systematically. The station, the position, the caput, the molding, the effacement, the dilatation, and membranes. That gives you a much more complete assessment of labor. Okay, now we come to a very important section. When should we consider transfer from midwifery-led care to obstetric-led care? And this is where the numbers become extremely important. Now, let's start with the maternal pulse. If the pulse is 120 beats per minute or more on 2 occasions, 15 to 30 minutes apart, this is a red flag. Next is the blood pressure. And notice that there are two different thresholds. If there is one reading of systolic blood pressure 160 or more, or a diastolic blood pressure of 110 or more, that alone is significant. You don't need to wait for repeated severe hypertension before escalating care. But for the lower threshold, systolic blood pressure of 140 or more, and diastolic 90 or more, we are looking for two readings 15 to 30 minutes apart. So here, exam question or SB memory trick: severe BP 160 by 100, one reading, or hypertension 140 by 90, two readings 15 to 30 minutes apart. These are exactly the kind of small numerical distinctions that could turn an apparently easy SBA into a trap. Let's continue with the maternal red flag sign. First, we will discuss about the respiratory rate. But before that, I want you that revise previous as well. Now, first, the respiratory rate. A respiratory rate of less than 9 or more than 21 breaths per minute on 2 occasions, 15 to 30 minutes apart, should prompt consideration of transfer to obstetric-led care. Again, notice that we are not just looking for tachypnea, and abnormal low respiratory rate is also concerned. Next is proteinuria. If the woman has 2 plus proteins on urine analysis together with a blood pressure of 140 by 90 or above, this is another red flag requiring obstetric assessment. And then we have temperature. This is another beautiful SPA number. A temperature of 38 degrees Celsius or above on one occasion is sufficient. Alternatively, a temperature of 37.5 degrees Celsius or above on 2 occasions, 1 hour apart, is significant. So memorize the distinction: 38 degrees Celsius once and 37.5 degrees Celsius twice, 1 hour apart. Why are we concerned? Because intrapartum pyrexia may indicate infection, including intraamniotic infection, and can have implications for both maternal and fetal monitoring and management. So these are not simply abnormal observations. They're telling us that the woman's risk profile has changed. Now, not all the red flags come from the observation chart. There are several other clinical findings that should make us reconsider what midwifery-led care remains appropriate, whether it remains appropriate. So first, fresh red vaginal bleeding. Remember that a small amount of blood-stained mucus, the normal show, is different from the significant fresh bleeding. Next is blood-stained liquor. Remember and consider transfer if the membranes ruptured more than 24 hours before the onset of the established labor. Why does duration matter? Because prolonged rupture of membranes increase the concern about the infection. Another important thing is meconium. The presence and character of meconium should trigger a full risk assessment and consideration of appropriate obstetric-led care and fetal monitoring. And then there is a very clinically important red flag: pain that is different from normal contraction pain. For example, persistent or unusual abdominal pain between contractions should never simply be dismissed as labor pain. Think about pathological causes and reassess urgently. Finally, there may be other maternal or obstetric risk factors requiring obstetric involvement. And remember this box on the slide, risk factors can have a cumulative effect. You know, so one borderline finding may not tell the whole story. Several concerns occurring together can significantly increase the risk and therefore increase the urgency of transfer. Now let's move from the mother to the baby. Which fetal findings should make us consider the obstetric-led care? Any point that comes in your mind that now this fetal finding, this is present, this should be done in an obstetric-led care? First, a non-cephalic presentation. So if the baby is breech, transfers, oblique, or another abnormal presentation is suspected, this is no longer straightforward low-risk labor. Second, in a nulliparous woman, a high or free-floating head is a red flag. And I'll give you the exact number on the next slide. Other important fetal factors include suspected or diagnosed morphogestation baby and particularly fetal growth restriction. Also consider oligohydramnios, anhydramnios, then very importantly, abnormal fetal heart rate monitoring and concern regarding the fetal heart rate needs appropriate reassessment and may require escalation of monitoring and obstetric care. Ask about the fetal movements as well. Reduced fetal movements within the previous 24 hours should not be ignored simply because the woman has now presented in labor. And finally, cord presentation. That is particularly important because of the potential risk of cord prolapse, especially if the presenting part is high and the membrane structure. So when thinking about transfer, don't focus only on maternal observation. Always ask, is there anything about the fetus presentation, growth, liker, movements of fetal heart that has changed this woman from low risk to high risk? Now, head height. This one deserves its own slide because it's exactly the sort of number an examiner can test. In a nulliparous woman, if the fetal head is palpable abdominally 4/5 or 5/5, यानी कि head felt above the brim or head not engaged with the pelvis or the head is free floating, consider transfer to the obstetric-led care. Remember these numbers. Let's understand 4/5 palpate abdominal is being how much of the head remains palpable above the pelvic rim. So 5/5 palpable means essentially the whole head can still be felt abdominally. The head I'm sorry for the technicalities and the difficulties that you're facing now, but I wanted to just complete the recording and I wanted to share it with you. I know that you're facing much difficulty today, and I have a hope that next time you are not going to face that. There are some technicalities. So I was here at high head. Whole head can still be felt abdominally. The head is high. And 4 by 5 palpable means that most of the head remains above the rib. In other words, the head is not well engaged. And notice that this criteria specifically mentions nulliparity. It is concerned regarding the engagement, the presentation, the liver progress, and particularly around the membrane rupture, the possibility of cord collapse. So if the exam question says nulliparous woman in labor, cephalic presentation, had fifth by fifth palpable abdominally, that number should immediately get your attention. Now, let's change the direction slightly and talk about the food, the drink, and gastric acidity during labor. Here is a question. Should every laboring woman routinely receive a proton pump inhibitor such as omeprazole? Yes, please. No. For a low-risk woman in labor, do not routinely offer a PPI simply because she is in labor. Am I clear? Do not routinely offer because she is simply in labor. This is an easy area to overtreat because we associate pregnancy and labor with aspiration risk. It is not like that. She is in labor. So when you should consider it, consider PPIs, such as omeprazole, if the woman is receiving opioids or if the risk factors develop that makes cesarean birth more likely. And that's your exam trap. Labor itself is not an indication for routine PPI. So if you get a straightforward low risk woman progressing normally in labor, don't choose routine omeprazole just because it sounds relevant. Am I clear so far? Okay. Next question that immediately asks is that whether a woman can drink or eat during labor. What is according to your opinion? What is according to your opinion that is drinking during labor is allowed? Yes, and then is drink force excessive fluid intake. In fact, isotonic drinks. Am I clear? Isotonic drinks may be more beneficial than water because they provide some calories while maintaining hydration. But it is an important part. Drinking more than avoids no additional benefits. Then excessive fluid consumption can actually be harmful. Why? Because of the risk of peripartum hyponatremia. During labor, the body's ability to excrete free water may be reduced, and excessive hypotonic fluid intake, particularly when combined with intravenous fluid and oxytocin, can contribute to dilution hyponatremia. Severe hyponatremia can cause serious neurological complications. So we don't tell women you in labor drink as much water as possible. Instead, drink to thirst, don't overdrink. That is both simple and evidence-based. Now let's tackle another very common misconception. Does every woman in established labor need to be kept nil by mouth? No. A low-risk woman may have a light diet during if she wishes. Routine fast not quite every woman. However, that works. If she has no review. Similarly, more likely reconsider intake because the possibility of anesthesia and operative birth has changed. So think dynamically. A woman may start labor as completely low risk and be able to eat a light diet. Later, if complications develop and cesarean birth becomes increasingly likely, the advice will change. So low risk established labor may, there's no routine fasting, and this is a good example of why intrapartum care should be based on women's current risk, not on outdated blanket rules. Now we arrive at one of the highest yield slides in this section. If you are preparing for exam, I want you to literally imagine this clock. During the first state of labor, there are 4 key time intervals to remember. First of all, 30 minutes, 1 hour, 4 hours, 4 hours. Let's break them down. Every 30 minutes, document the frequency of contraction. Every 1 hour, record the maternal pulse. Every 4 hours, record the maternal temperature, blood pressure, and respiratory rate. And every 4 hours, offer a vaginal examination earlier if there is clinical indication or the woman wishes after discussion. So your memory sequence is 30 minutes for contraction, 1 hour, 4 hours, 4 hours BP temperature respiratory rate, and 4 hours offer vaginal examination. Now be careful with the wording. We say offer. It is not there for explanation and consent. We say offer vaginal examination every 4 hours. It is not something performed automatically without explanation and consent. And observations may need to be performed more frequently if there is a clinical concern. So if an exam question gives you an uncomplicated woman in established first stage and asks, how frequently should maternal pulse be recorded? Your answer is hourly. Contractions, half hourly. BP temperature and respiratory rate, 4 hourly. Routine vaginal examination, offer 4 hourly. These numbers are exam gold. And now that we know what to monitor and how often, the next question becomes even more important. What do we do when labor is not progressing normally? Because in the next section, we are going to move from routine intrapartum care into assessment of progress, suspected delay, confirmed delay, amniotomy, and oxytocin. Before we move on, I want you to memorize one single line from this entire section. 30 minutes, 1 hour, 4 hours, 4 hours, that's it. Now attach one observation to each number. 30 minutes contraction, document the frequency of contraction every 30 minutes. 1 hour maternal pulse, 4 hours temperature, blood pressure, respiratory rate, and another 4 hours offer vaginal examination. So whenever an exam question asks about routine observation during the first stage of labor, don't try to recall 4 separate recommendations. Just remember 30, 1, 4, 4. Contractions, pulse, temperature, blood pressure, respiratory rate, and vaginal examination. This is one of those lines I would definitely memorize before going into exam. Now, one important clarification. I don't want you to leave this lecture thinking vaginal examination means every 4 hours, no matter what. No. In established first of labor, we routinely offer vaginal examination 4 hourly offer, but it can be offered earlier if there is clinical indication, particularly if there is concern about the progress of labor. It can also be performed earlier if the woman wishes after discussion. And before performing the vaginal examination, don't immediately put on gloves and start the examination. First, perform abdominal palpation. Why? Because you want information about the fetal lie, the presentation, the position, the descent, and how much of the head is palpable abdominally. Also assess the vaginal loss. Then if vaginal examination is indicated and the woman agrees, proceed with the examination. And remember the language here. We offer a vaginal examination. We explain why it may be helpful, obtain consent, ensure privacy and dignity, and respect the woman's preference. So the example is the clinical indication and the woman's preference are more important than rigid clock watching. 4 hourly is the routine interval. It is not a rule saying that vaginal examination can never be done earlier. Okay, before we finish part 3, let's do a rapid numbers recap. I want you to answer these in your head before I say the answer. Epidural. After establishing regional anesthesia, how frequently should blood pressure be measured immediately? Every 5 minutes for 15 minutes. If pain is not relieved satisfactorily after the epidural, review at 30 minutes. Sensory and motor block, assess hourly. Now, second stage with epidural. Passive state, nullipara, remember 2 hours. For multipara, remember 1 hour. Next term is like it is second stage, passive second stage we are talking about. Okay. Now, term pre-labor rupture of membrane. If labor has not started, when should she be reviewed? Within 12 hours. And approximately how many women will go into labor spontaneously within 24 hours? Around 60%. How long can expected management generally be offered? Up to 24 hours. But now I changed one detail. She is GBS positive. 24 hours? No. Offer immediate induction of or if had been and finally for example, progressive cervical dilatation from respiratory rate 4 hourly and vaginal examination offered 4 hourly. These are the numbers I want you to take away from our part 3 of intrapartum care. Now let's see whether you actually remember them. I'll give you the question, pause for a second and answer before me. A woman at term has pre-labor rupture membrane and is known GBS positive. Wait for spontaneous labor for 24 hours or induce immediate induction of labor. Okay. A woman reports possible leaking, but you are uncertain whether the membranes have actually ruptured. What examination? Speculum examination, not routine digital vaginal examination, simply to diagnose the rupture of membrane. According to this guideline, when does the established first state of labor begin? Regular contraction with cervical dilatation from 4 centimeter. Routine vaginal examination in established first state. Offer 4 hourly. Maternal pulse hourly. And frequency of contraction document every half hourly. If you got all 6 right, then the important framework of this section is already sitting in your head. And with that, we complete the intrapartum care part 3. Now I want you to notice something. This topic initially looks overwhelming because there are so many recommendations and so many numbers, but don't try to memorize the guideline. First, master the important numbers, then understand why the recommendation exists, then understand. Once you understand the reasoning, the question becomes much easier because even if the question is presented as a clinical scenario, rather than a direct recall question, you can still work your way towards the answer. So master the numbers, understand the reasoning, then the SPA becomes easy. And we are not finished with the intrapartum care yet. In the next part, we are moving into the one of the most clinically important and most testable areas, progressive labor, suspected delay, confirmed delay intervention. We look at how to recognize when labor is generally delayed, when to reassess and when amniotomy is appropriate, when oxytocin comes into the picture, and importantly, when not to intervene. That section is packed with SBA traps, so make sure you understand today's foundation first. Intrapartum care, part 3 complete. See you in next part in OBG with Sadia, please.